I'm currently working with Mrs. Tubbs in the management phase of mechanical ventilation. Mrs. Tubbs' typical COPD arterial blood gas is a compensated chronic respiratory acidosis with mild hypoxemia. Her last gas values are pH of 7.36, a PaCO2 of 79, a bicarb of 43, and a PaO2 of 61, which is a stable arterial blood gas for this patient with emphysema or COPD. Special precautions I will need to consider as I'm weaning my patient to the minimal ventilator assistance during the weaning phase is that this disease process causes high lung compliance and high airway resistance, which leads to auto trapping. So I need to make sure as I'm weaning her, I'm giving her plenty amount of time to exhale. So I need to make sure she has extended expiratory time and attempts to prevent auto PEEP and air trapping. I'm also want to make sure that her spontaneous tidal volumes are about 6 to 8 milliliters per kilogram ideal body weight. So I hope to see them about 300 to 400 milliliters. I also want to make sure as I'm weaning her that I'm only weaning one thing at a time. I want to make sure if I'm going to change her rate, I change her rate and then take some time and wait to see how she reacts to that change. And then go in and wean her FiO2. So I want to make sure I do it one thing at a time because I don't want to go in and change a whole bunch of things and then she starts going downhill and I don't know which thing I changed caused the problem. So I want to make sure I wean her one step at a time. Mrs. Tubbs currently on the following settings. She's on a mode called BCSIMB. Her set tidal volume is 450 milliliters. She is currently on a rate of 10 breaths per minute. Her spontaneous tidal volume is 250 milliliters. Her total rate is 13 breaths per minute, and her pressure support and her PEEP are set at 5 centimeters of water, and her FiO2, she's on 35%. Her vital signs are stable and normal for her age and her cardiopulmonary disease history. Her SpO2 is 91%. The attending physician, Dr. Nose, wants me to wean Mrs. Tubbs to the minimal mechanical values of SIMV to a rate of 4 due to her long-standing COPD. I would perform these changes to her rate by decreasing her rate 2 breaths at a time, and then I would wait about 30 minutes in between each increment of 2 I drop down just to see how Mrs. Tubbs is tolerating and make sure everything's going to plan. I would manage her FiO2, pressure support, and PEEP by leaving them on their current settings because you can wean a patient off of the vent on an FiO2 of 35% and a pressure support and PEEP of 5 centimeters per water pressure. Those are good settings to wean off of. To assess her oxygenation, I would use a pulse ox or transcutaneous monitoring, and to get a more accurate view of her oxygenation, I could do an arterial blood gas, and that will give me the most accurate number to see how she's really oxygenating. I would assess her ventilation by using capnography or transcutaneous monitoring, and once again I can also get an ABG to assess her how well she's ventilating. The other patient assessment skills I would use to assess Mrs. Tubbs, I would look at her color. I want to make sure she's pink and not cyanotic. I want to check her heart rate. I want to make sure she is not tachycardic. I want to make sure she is not tachypnic, which is a high respiratory rate. I want to make sure she's taking nice, slow, deep breaths. I want to make sure she's getting an adequate tidal volume of at least 300 milliliters. I'll take 250 milliliters for a spontaneous tidal volume because once again she has been on the vent for a while, so her respiratory muscles are a little bit weaker. And I would also want to assess her level of alertness, because right now, if I were to ask Ms. Tubbs a question, she could shake her head yes or no. I wouldn't want to come in here after I did some vent changes and come to find out that she's unresponsive and lethargic. That would just not be good.